Thank you, Rachel. So as Rachel mentioned, each year the membership of the Midlands Decision Support Network select 3 topics that are of interest to them. Now they ask us to carry out some sort of detailed analysis on those 3 topics. And this is the last of a set of 3. So the other ones that fit in this group were a report that I worked on, which looked at strategies to reduce inequalities in access to planned hospital procedures. And Paul Seamer presented fairly recently to this group on a piece of work he did to understand the clinical groups that seem to have experienced most of the negative impacts of reduced access to care during the COVID pandemic. This is a project that Andrew's been working on for a little while. It's been a challenging project, I think, fair saying, to work on. We're hoping to release a report to the membership next week, with a view to releasing it on our website a couple of weeks after that. The challenge with the piece of work has been about how to frame the findings in a useful and constructive way. We think there's something really important in the findings that we've generated, but communicating those effectively has been challenging for us. So we kind of really want to hear your feedback today on the work that we've done and how we framed it. So yeah, genuinely interested in your feedback at the end of the session today. It's worth saying we've already had lots of feedback, more than any of the report that we've produced before. We've gone out and sought feedback from lots of experts in the field and individuals that we think might have a view on it, and those are being incorporated into the final draft of the report. But it's never too late to get other useful comments. So if you hear things today, or you have ideas about how we might frame things to make the key findings in the report, which we think, as I say, I think are really important, to make them land better, then please do let us know. We'd love to hear that feedback. I think that's all I was going to say. I was going to hand over to Andrew to take us through the work.
Thanks, Stephen. Okay, so I'll start with the simple ideas, and that would be the broad purpose of a diagnostic test. So that is to assess an individual's state of health. Now, doctors might use the results of these tests to monitor or rule out a condition, or commonly to arrive at a medical diagnosis. So a key report on diagnostic services released in 2020, the Richards Review, categorises current diagnostic services into 5 distinct pillars or groups. Now, traditionally, well, let's go through them first. So we've got endoscopy, which is inserting scopes into the body; genomics, which is about genes; imaging, which includes CT, MRI, ultrasound, X-ray; pathology, for instance, blood film examination; and physiological measurement, which includes things like spirometry and electrocardiograms, not to be confused with echocardiograms. So all these services have been delivered by provider trusts in hospital settings. However, this model is now changing with the introduction of community diagnostic centres, or CDCs, I'll call them. Through CDCs, the NHS is hoping will separate elective and urgent diagnostics, and this should, in theory, improve throughput in both cases. So why do diagnostic services matter? Okay, let's say you're unwell. Generally speaking, the earlier you are correctly diagnosed, the earlier you can begin correct treatment, and the better outcomes will be. So the NHS has perhaps a little slowly recognised that diagnostic services are key to improving outcomes across health, especially for those priorities like cancer, cardiovascular and respiratory diseases. So we've seen referrals to diagnostic services and diagnostic activity grow rapidly in the last decades. And there's no sign that this growth in referrals will slow, and I'll touch on this later. So here we see how demand or referrals and supply or activity for echocardiography has changed over time. This is from the diagnostic activity and waiting times data that NHSE publish monthly. This graphic includes demand and supply for tests for both urgent and elective care patients. Here we see three other key tests: colonoscopy, CT, and in all these cases, we see that demand has almost trebled in the period from 2010, while activity, at least for colonoscopy, CT, and MR, has doubled. Now, demand for diagnostics, these services, is growing for many reasons. For example, population growth and morbidity levels, which influence the number of health contacts for a population, and they'll influence, all else being equal, the number of referrals to diagnostic services. But we've also seen many factors that influence clinicians' tendency to refer to diagnostic services. These include new policies, perhaps lowering the threshold for testing. And I mentioned the benefits of early diagnosis, but increased testing might also reduce unnecessary admissions. It might reduce instances of missed or incorrect diagnosis. It might reduce length of stay and the risk of mortality for patients who are admitted in emergency. May reassure both patients and clinicians, and it also might facilitate hospital discharges. So most of these have been studied, and there's evidence to back these up. So it's no wonder that healthcare policy should pick up on this. But another factor in our list is, say, capacity or supply-induced demand, the sort of build it and they will come idea. There is greater diagnostic capacity available nowadays, meaning clinicians have greater access to CT and MR scanners, for example, and so they're more likely to use them in practice, and perhaps they're less likely to see them as a scarce resource to which access must be limited. So the purpose of our work was to identify, describe, and loosely quantify the unintended consequences of the growth in testing, or perhaps more precisely or specifically, clinicians' tendency to test, their tendency to test in the last decade or so. Now, this growth will have affected countless processes across primary, secondary, and tertiary care, but we chose to look at effects on selected hospital processes. And I'm actually going to start and probably end with the most contentious part of our work, and Stephen's going to like this. How has increased diagnostic testing affected elective care waits? So to help illustrate events in a typical elective pathway, let's look at John's experience. Now, John's particular pathway involved several appointments with a consultant and her team. The consultant also referred John to 2 different diagnostic services for 2 separate tests. So the results of these tests indicated that John required treatment, and they also indicated the type of treatment that might be useful. But both referrals to diagnostic services in this case took several weeks. So John joined a separate waiting list for each of the diagnostic tests requested by his consultant. And both tests, after they were done, he revisited his consultant to discuss results and implications of these tests. So it's probable, therefore, that John's pathway, which involved these separate tests, several separate tests, was longer in duration than pathways involving one test or fewer. So if we step back from John's case to think about all elective pathways, we would expect that if clinicians request more diagnostic procedures per pathway and all else is equal, diagnostic waiting lists will grow, and so patients will wait longer for their tests, and so they'll wait longer to receive treatment. So how has the number of diagnostic procedures per elective care pathway changed in recent years? Okay, so every month the NHS publishes their monthly diagnostics waiting times and activity data, and this is for 15 key diagnostic tests. So this includes a time series providing the number of diagnostic procedures delivered to elective patients. You can see here this number doubled between 2008 and 2020. In a separate publication, we get monthly data about the number of open and completed referral to treatment pathways and the median waiting times of these pathways. Now we combined these time series to estimate how the number of tests per pathway, which we call the diagnostic referral rate here, has changed in recent years. So, for example, at the start of the period, in August 2007, that is, the NHS performed 62 tests for every 100 completed pathways. By April 2015, this had risen to 107 tests. So this is just over midway through the period. 107 tests for every 100 pathways, which is an increase of almost one extra test for every 2 pathways completed. So what has been the impact of this rise in the referral rate, and how could future rises in the referral rate affect RTT times and the elective waiting list? So we prepared a simple model to contrast the true course of events over the last decade, that is, this rise in the diagnostic referral rate, with a scenario in which the referral rate remained constant. This latter scenario we called our counterfactual scenario, meaning one that happened, a scenario that might have happened but didn't. So our aim was to look at how a relatively modest change in the diagnostic referral rate might affect elective care flows over several years. So we set our starting point as January 2012, when health professionals requested on average 87 procedures per 100 pathways. And our endpoint was 8 years later, which is January 2020, the same month that COVID-19 first appeared in the UK. At this time, we saw 103 tests per 100 pathways, but the level, as you see, had remained comparatively stable for 5 years or so. So we sought some indication of the outcomes we might have seen had there been no growth in diagnostic referral rates over this period. We imagined, therefore, that diagnostic capacity increased as it did in reality, but that the referral rate remained steady. So here we go. From January 2012 until January 2020, it stayed at 87 procedures per 100 pathways. So in this case, all else being equal, we have greater capacity and fewer referrals, which should mean the waiting times for tests would have decreased. We also assumed that the decrease in the waiting time would have been proportional to the difference between factual and counterfactual activity levels. So, for example, if there was half the activity in the counterfactual scenario, half the diagnostic activity in the counterfactual scenario, waits for diagnostic tests would have been half as long. Now, since RTT times include the waiting time for diagnostic tests, RTT times in the counterfactual scenario should also have decreased. That means that new pathways could therefore have begun earlier, and more pathways could have been completed in a given time period. So we tried not to overestimate the impact of increases in the referral rate. For example, we've assumed that health professionals requested all of a patient's tests at the same time, rather than requesting one test and then get the results, and then another test and then the results. And we also assumed that just half of RTT pathways involve a diagnostic referral. So there are obvious limitations to this approach, and let's remember that models are always simplifications, abstractions of real world processes. But we think this is a good enough model to illustrate the overall impact on elective care, and just as importantly, to stimulate discussion. So as for the results, we see that for the individual patient, changes to RTT times would have been quite modest. So here is the median RTT time on the vertical axis, and then month on the horizontal. And we see the median time for the factual and counterfactual cases. So when the referral rate was held constant in the counterfactual scenario, the median RTT time for a single pathway, which was often around 40 days, was reduced by only 2 days at the most. However, over the 8-year period, the NHS completed 120 million pathways. So if each of these pathways was just a day or two shorter, we would see that many more RTT pathways could be completed in this period, and the size of the RTT waiting list would also fall quite considerably. So if we contrast our counterfactual scenario with reality, around 3 million more patients might have received treatment by the end of the period. This is the cumulative total here over time. And from an operations perspective, the NHS might have entered the pandemic with a comparatively modest waiting list of 1.5 million, compared to the all-time high of 4.4 million that we saw in reality. Now, I'm not suggesting that holding the diagnostic referral rate constant over the last decade would necessarily have been a desirable course of action. This is only to illustrate that along with the clear benefits of increased diagnostic testing, comes the potential for harm. Now, lives will undoubtedly be saved by increasing access to diagnostic services, but lives will obviously be lost if millions of people have to wait longer to receive treatment. And it's obviously about balance. So we're hoping that the NHS will do some more work to better understand this balance, and understand whether and how they might accommodate more testing without increasing waiting times for elective patients, or indeed adding the pressure on diagnostic services. So this was just one aspect of our report. We also did We use different models to examine the impact on waiting times in A&E and the length of stay for admitted patients, and also bed occupancy. But to do them justice, I think I'd have to spend more time than we have here. So perhaps Rachel, I will come back and present sometime in the future on them. But I'll see if I can summarize. Well, so I looked at sort of several factors that have influenced diagnostic demand over the last decade. And these are actually all continuing to drive demand. And in many cases, their influence is growing. So the Richards review suggests that ICSs should plan for demand growth to continue at current levels for the next 5 years for most modalities. And this is likely to be demand is likely to grow faster for things like CT, and in this case, perhaps by as much as 100% over the next 5 years. And current diagnostic policy aims to increase access to diagnostic services by increasing both their capacity and their efficiency. So capacity through CDCs and efficiency with improved digitalization, pathway reform, AI reporting tools, and CDCs again, for example. So these are obviously going to increase diagnostic throughput, but unless they are carefully moderated, it's our belief that they're also likely to create further sort of supply-induced demand. And we've seen some evidence of that here, and we provide more evidence of that in the report itself. So and unmoderated increases in diagnostic activity are just as likely to exacerbate the problems I've been talking about as they will mitigate them. And finally, so we think there are two policies or interventions the NHS could consider, perhaps even above and before increasing efficiency and capacity. So a clear priority for us is to eliminate unnecessary testing. And estimates suggest this might be 10% or more of all activity, all diagnostic activity. And this has numerous benefits, like improved patient safety, shorter waiting lists, and indeed reduced costs. It would also free up capacity, diagnostic capacity, and may allow sort of allied services, those services that have to respond to diagnostics, some time to stabilize before further growth. And the resources and technology to reduce waste already exist. One solution is to employ tools that aid diagnostic referral decisions. So, yeah, help the clinician decide whether or not it is beneficial to refer to diagnostic services in a particular situation. But the key point here is that such tools must be embedded into processes and practice, or they will not be used. And our second priority was that diagnostic services take full advantage of risk stratification tools. So in many cases, rapid growth in demand coupled with the activity backlog means that some in urgent need of a test are not receiving a timely test. So risk stratification tools, for one, allow services to direct capacity to those with the greatest need. Yeah, so I think I'll leave it there. But yes, shall I stop sharing my screen and perhaps we can answer some questions if there are any.
Thank you, Andrew. That's I know it's been a very interesting piece of work, and I think lots of people are interested in the output. There are a couple of questions, but before I look at those, Stephen, do you want to come in there?
Yeah, I thought I might just quickly summarise the findings in the other two areas that Andrew mentioned. So Andrew's focused when talking to you today about the impacts on the RTT pathways, but as Andrew said, we did some work on the impact of growth in testing in emergency departments and also on inpatient wards. And the sort of headline conclusions from those sets are that increases in diagnostic testing in EDs, which have been really substantial. I mean, patients are something like four or five times more likely to receive an MRI or CT scan now than they were only a few years ago. That's how quickly the use of these tests have grown in ED. That growth has contributed to the slowing down of progress through people through EDs. We've seen waiting times increase. Part of that, at least, is attributable to the fact that we're doing far more tests in ED than we used to before. And it's not just the people who are being tested that are slowing down. We're slowing the progress of all people through ED because we're doing more tests, and clinicians' time is spent more ordering tests, reviewing the test results, incorporating those test results into patients' clinical regimens. So so that's what's happening on ED. On inpatient wards as well, we've looked at the increased use of testing once patients are admitted, and we can estimate the consequence of that for occupancy rates on inpatient wards. And we think, the increase in testing has added 1 or 2% to occupancy rates on average across hospitals over the last few years. Occupancy rates that are already, very, very high. We've made that even more challenging by increasing our rates of diagnostic testing. And as Andrew said, what we're not saying in this report is that we shouldn't be increasing diagnostic testing results. But at the moment, the only thing that's limiting our rate of diagnostic testing growth is diagnostic capacity. And we're not thinking enough, we don't think, about the consequences of that for the flow of patients through hospital and what that means for patients' care. And what we're trying to highlight really is that there are some downsides to this, at least in the current way we're approaching it. There are harms associated with the fact that we've rapidly increased diagnostic testing, not just the benefits. And we'd want people to focus a little bit on the trade-off that exists between making more and more tests available to people and the benefit that has for early diagnosis, and the slowing down of our clinical processes that would normally that we think is really important. I mean, it's important that people get care quickly in ED. It's important that people get care quickly if they're waiting for an elective procedure. And we're not focusing enough on those negative consequences at the moment. And that's what the report is really trying to get us to do, to see that there is a balance, a trade-off going on here that we maybe aren't really usually focusing on. I'll stop there and hand over to questions maybe.
Thanks, Stephen. I think people will look forward to receiving the whole report, which I think you're saying is due next week. And I know that for a fact because that's the first point that was made on the questions. So if people by all means shout out if you want to raise a question, but I'll just go to those which have been put on Menti in the time being. So I'll just share my screen. No, that's my inbox. This looks very much like the Menti questions that we're interested in. Rosie, do you want to have raise a point before I go through these? Okay.
That was so interesting. So my name is Rosie Smithson. I'm the qualitative research lead for the ICB in the Black Country. And Steve, I think already knows that we've been doing some work on the hip arthritis pathway following the socioeconomic report about most high deprived patients not getting through to elective care so much. But actually what we ended up looking at was the whole patient's journey through the MSK pathway, and your results chime well with the results of our research. Really, we found a lot of patients were being sent straight through to secondary care for diagnosis in terms of CT imaging in order to diagnose their arthritis, rather than the actual get it right first time pathway, which is about actually they should be a physical examination. I don't understand it completely myself, but about functionality, etc. You don't actually need that test to diagnose arthritis. And so doctors were sending patients straight through, and patients were pushing for them because patients want these diagnoses. They want to understand, they see that as the sort of golden ticket, I think, in terms of progressing themselves through. But actually what they should have been doing was going through to first contact practitioners or advanced physiotherapists for assessment and triage before they got anywhere near secondary care to start having that level of diagnosis. So it was just really to flag up that we found that, I think, and I think it's both clinician, as you say, behaviour, that they feel they want to get that expert opinion from the CT, from the imaging, and that it's going to satisfy the patient's demand because they want the answer to their condition, whereas actually the conservative management steps that aren't really being taken at the moment are probably a bit harder for patients to swallow. The fact that you can actually just move my legs around, and yes, you've got arthritis, and actually you're not ready for surgery yet, what you need is physio. I feel probably the psyche of the patients is that they want that. So I think what we found was some of this unnecessary diagnostic testing within the research, and consequently patients waiting for those tests, multiple tests going on at the same time, then waiting for their diagnosis, and in between actually not getting the conservative care and the actual comprehensive assessment they needed through the physio triage. So one of the things that we're looking at is very much around shared decision making of patients, so they actually understand the logic behind that and they don't need the diagnostics. But obviously there's that key barrier as well from the GPs still sending straight through to secondary care to get that diagnosis, and then changing the way, the pathway, and looking to other professionals like the FCPs to make those diagnoses. Sorry, that's quite a rambling summary. Does that make sense?
Yeah,
it does.
Yeah, thanks, Rosie. So Stephen or Andrew, do you want to say anything in response to that before I go to Mike, who's got his hand up?
I won't comment particularly on the hip replacement pathway. And part of the challenge with this report has been that, we're trying to provide an overview of an issue, but obviously what sits beneath it is a huge amount of detail on specific pathways that you could have individual debates about. But one of the themes I think of that is about this search for certainty, which diagnostic testing seems to offer, and that trajectory seems almost immutable. It's obviously you can't do anything about that. That's what people are going to want, both clinicians and individuals. But again, the purpose of the report is to kind of highlight just one aspect of the potential downsides of that, just one aspect of it, which is that in seeking for that, we have to expect probably slower pathways unless we explicitly mitigate those effects. And I don't see that we're doing that substantially at the moment.
Okay, thanks very much, Stephen. Mike, would you like to come in here?
Yes, no, I thought it was a fantastic piece of work and really nicely presented. And briefly mentioned was risk in terms of the risk of over testing, or if you build it, they will come. If you keep providing the service, it will just expand and expand and overload everything else. But I wondered if there was another component of risk there, which is the fear of making mistakes or wanting to follow the NICE guidelines precisely. And we must be absolutely sure before we do an invasive procedure. And that might be a fear on behalf of the patients, but also maybe some other clinicians, whether hospital, GP, they want to be certain, they don't want to do anything, they want to make sure they follow the process. So, I's are dotted and T's are crossed. I wondered if you could just comment on that in general as a different form of risk or risk aversion.
Yeah. That's defensive medicine sort of angle, I think, maybe getting at that. I think it's funny how these one of the things we might want to try and track at some point in the future is how these tests become adopted at such high levels within clinical practice. And that's not always driven by clinical guidelines. It's driven by much more subtle factors, I think, over time. and sort of clinical norms change very slowly, but in a particular direction, it seems, towards more testing, such that people who've been in the profession a long time will remember very, very different ways of working, which were regarded as satisfactory then. I guess the key thing for us is that we have to acknowledge that we're making in the NHS choices to increase the availability and the capacity of diagnostic testing. It's not something that's happening to us so much as something we're choosing and enabling. I guess the point is just that we do that with open eyes of the consequences of that, not just the benefits. And we kind of feel that a lot of the policy debate at the moment is just about how we can do more, how can we do more of these things, without just thinking about what the potential downsides of that is. And we focused on the downsides in terms of flow, but there are harms associated with the tests themselves, you know, and all the anxiety that might be generated by extra people waiting for test results, when possibly for a lot of them there's very little wrong. The marginal gains you get from ever increasing test availability. So there are other angles on this that we haven't focused on in the report, but I think we need to be more open to thinking about the negative consequences of increasing diagnostic capacity as well as all the benefits.
Thanks, Stephen. So we do have a couple of questions and points on Menti, which I will go to just very shortly. But just my personal reflection on this is in fact, so my dad's in hospital at the moment, so I'm having some very close inspection of what's going on out there, and that huge sort of from a personal sort of perspective, wanting to have the tests done, but also realizing that what he really needs is to have everything sort of like minimal intervention and come home, because what he needs to do is get out of hospital is what he needs. And so what I realized was he was waiting for test results, and that was taking days when he shouldn't really have been in hospital, you know. So there's going to be that balance, and I can see it from, you know, from all the different angles, but wanting to have that concrete sort of information and the best care and the best solutions, but also knowing he should be at home really. And anyway, so let's just have a look at what people have been saying. I'll just share my screen. So like I said before, the first comment here is around the fact that people want the report, which is great. So will the report be circulated? Stephen, you mentioned that we're aiming for next week, and it should be on the strategy unit website and on the Midlands Decision Support Unit website soon. So that's that point. If I just
just to be clear on that, so our usual practice these days is to release the report to the Midlands Decision Network about 2 weeks before we put it on the website, just to give our local members who have requested the report time to familiarise yourself with the content and before it gets wider release.
Okay, so we've got time to cover a few of these questions or points that have been raised. So if you can see the first one I've got here, which is asking, can you identify change in diagnostic opportunities in the growth path? For example, MRI was a super specialist in the early days, but then became mainstream between 2010 and 2015, and therefore has the plateau been aligned to the normalisation of MRI? So it's the impact of availability and technology increasing. So have you got anything you'd like to add to that, Stephen or Andrew?
Andrew, are you able to comment on the long-term trends in MRI scanning activity rates?
I can't remember. I mean, they are increasing 6% annually. Yeah, this question is about the sort of the plateau. It could well be partially attributed to the normalization of MRI, but MRI is just, so we looked at all tests, and MRI is just obviously a single test. There are likely to be many other factors there. So the number of we're looking at tests per pathway, and the number of pathways from 2015 onwards has also increased quite. It was stable, and then it increased quite rapidly. So that ratio and the plateau is also a consequence of the fact that the number of pathways completed has also risen. at the same sort of rate as the test, the number of diagnostic tests has risen. So whether that's sustainable or not, we don't know. Looking at the longer term trends, the rate of growth of diagnostic tests has been very, very steady since sort of 2007, whereas the growth in the number of pathways sort of increases, plateaus. So we think perhaps there is potential for that plateau to sort of end and sort of the ratio to increase again.
Thanks,
maybe just to
Andrew.
say that the policy is to expect increases in, at least continued increases in MRI scanning, and the other sort of point of reference is that our rates of MRI scanning are substantially below other developed countries' scanning rates. So there's good reason to believe MRI scanning rates will increase further, I think. If it doesn't happen, it won't happen because of capacity, not because of policy, I think.
Okay, thanks both. Sarah, would you like to come in there?
Sorry, I was just finding my, yeah, sorry about that. Hi, hello.
Hiya.
I just wondered whether you had any thoughts about patient access to results of all of these tests. And I raise this because as a governor, I've had patients coming to me saying, we haven't been allowed access to these results, it's, you know, and demanding, wanting to know the detail. And then the NHS piece saying, no, it's private and confidential within the NHS. You can only have access if you make a formal request for access to your records, which of course takes months, or, you know, it's quite a very difficult and formal process. So I just wondered if you kind of considered that, because it's all part of the kind of ethics of a lot of things. Yeah.
Well, I don't have a view on the ethics of it, although not just because I haven't spent much time thinking about it, but I think it's pretty obvious to know, it's pretty clear to me what would happen if we do. And one of the things that what Andrew highlights in the report is this issue that we might test a patient for a particular disease, but identify something else that we're not expecting. Or we get findings which are inconclusive and may require additional tests. And at the heart of clinical practice is a risk judgment, really, about whether or not some diagnostic tests are worth doing or others, or some procedures are worth doing. And I think if patients do get increased access to their test results, then those risk decisions will be more difficult, because they'll have to take place with the patient on the same page. And that at the moment, I think that there's a skills challenge for the NHS about how it might manage those sorts of situations. I think without intervention, we should expect that if patients get access to their test results, that will probably lead to more tests. That's contentious. I don't know, Sarah, what you were thinking. What you were thinking the ethical issues are. I'm sure there are lots. What was your perspective?
Well, so for example, getting things are quite disjointed, I think, in many places. So I'm not talking specifically about my area, but and so sometimes it's quite hard work for the patient to pull together all the right bits, and sometimes you need access to one thing in order to be able to have a conversation with another bit of the NHS, and just double check that things have sort of been followed through with some continuity. And the particular patient who came to me was very frightened that they were on the cancer pathway and there were different bits of them. And of course, because they were sent to different specialities, they were getting very frustrated with understanding where they were and then not being allowed to have the detailed access to the reports and things like that. So I can see it from both sides. I can see how it can chase, but at the end of the day, you know, you are responsible for yourself as well, aren't you, to kind of follow things through. And I think if everything was perfect and there was easy access and nothing got lost and nothing fell through the cracks and all of those things. And I can see that it wouldn't be necessary, but I'm just not sure we're there at the moment.
Yep.
Okay, thanks. Thanks, Sarah, for that. So if we've got one or two more questions on Menti, and I'm still sharing my screen, and I've highlighted the next one. So I'll be if Andrew or Stephen would like to respond to that one. Hopefully you can see
this
it.
one about the assumption that clinicians tests all the same. Yes, we actually started off not having that assumption, but we were going for sort of conservative estimates, and so we added it because it would produce the most conservative results. It's obviously not going to be true in, I don't know whether, I assume the majority of cases all tests are done at the same time, but there's obviously going to be a good number where they're not, and in that case our results are going to underestimate the effect there. This is obviously we just had this assumption for elective care. Stephen, did you have anything else to add?
Yeah, no, that's the same answer I was going to give. That we chose to adopt that assumption because we didn't want to overestimate the effects, which we thought were already quite stark. We thought we'd rather have conservative assumptions that would, so that the assumptions didn't get away of the discussion about what we should do about it, really. But no, we have made that assumption on the RTT pathways, but we've done it deliberately because we didn't want to overestimate effects.
Okay, I think we've got time for two more questions. So I've just highlighted this one, which says, in the first chart, what exactly do you mean by demand? Huge gap between demand and supply suggests hundreds of thousands of tests do not ever get done. Does demand perhaps include multiple referrals for the same test? If you'd like to respond to that one, Andrew.
Yeah, so it's monthly demand and monthly supply. So those it might be slightly misleading. I think that's a common way to present these things. So yes, if the unmet demand, if there's unmet demand in 1 month, it will probably be met in the following months, but it will just roll over. Demand, how do we define that? So it's those on the waiting list plus the activity done. So the supply is a component of the demand.
Okay.
In any month. Yeah, I think that's all I need to say right now.
Okay. Okay. Thanks for that.
And again, those are set out in detail in the report. And
yeah. All of the detail of the approaches, the assumptions, and so on and so forth. We could probably do a huddle on each and every single aspect of all of that. But this is really just to introduce people to the fact that the report is here. It will be here, and you can find out more about all of the detail when it comes. Let's do one more point before I sort of go on to one or two other things I would like to tell you about. I'm picking and choosing here. I will just click on this one here. So did you manage to establish that waiting for the diagnostics, not shortage of a clinical time, was a limiting factor in total RTT time? With a further question around if fewer tests done, maybe not to just mean that people wait longer between tests and seeing clinician. Do you have is that something that you can respond to quickly?
Yes, I can answer it in a slightly different way. When we looked at the ED models, for example, the emergency department models, we looked at what the impact was of having a diagnostic test on your total duration in ED, having control for various other factors, case mix type factors, time of day, etc. And so what we were measuring really was the impact in the net impact of having a test, rather than just the time it took to do the test. It's the net impact of having a test on your total duration in ED. And so for some tests, we actually saw that having the test reduced your duration in ED because Presumably having the test gave greater certainty to the clinician to discharge or admit earlier in the process. But for the majority of tests, I think it's fair to say having a test increased your stay in ED, particularly the scans. They added considerable amount of time. So we're not measuring the time of the test. We're measuring the time impact of the test on your pathway. That might be negative, might be positive. We were looking at those net effects.
Okay, thanks very much for that. Okay, I'll share the other questions with you. Whoops. I'll share the other questions with you after today, but I just would like to thank you again for coming, Andrew and Stephen, and for sharing those insight into this report, which is going to be shared in the next few weeks. I think we've just sort of highlighted some of the things that, if taken on board, could and should have an impact on what people feel about the number of tests which are being administered. Okay, so thanks again both. So just moving on, next couple of huddles, we've got the strategy unit's new data science team. That's going to be Chris Bealey and Zoe Turner. They're going to be telling us about that team and what they have planned for us all. We'll be finding more out about reproducible analytical pipelines, and there's a lot more huddles that I've got arranged for you as well. Diverse topics, and finally, please do go to the training and events website. The new prospectus will be out soon. We're booking in dates all the time for existing courses, and there will be some new ones as well. And please register for the Health and Care Analytics Conference. Yes, so that's in July. With the tickets are selling fast, like I mentioned before. So please get involved with that. It would be great to see you in Birmingham. And there's a couple of training courses here that Fraser Batty is delivering. The first one is the Economics for Non-Economists, and that's a face-to-face in Birmingham on the 27th of February. All of the details are on the website. Highly acclaimed, has excellent feedback. People love that, and they also love the thinking tools for decision making. That's also with Fraser. That's on the 13th of March. So with that, I 2 minutes over, but that's okay. Thanks again, everybody. Thanks for coming, and we'll see you in a couple of weeks. Okay, bye bye.
Thank you.
Thanks, Rachel.
Bye.